salvage surgery in a very big Irish wolfhound, presented with a history of lameness for a few weeks, and on radiographs there was evidence of a lytic and proliferative lesion in the distal radius. And so we discussed all the options with the owners, and they were pretty keen not to have an amputation. We talked about radiation therapy, a number of other different things, and finally the owners decided that they wanted a limb salvage surgery. So we are doing an endoprosthesis-based limb salvage surgery using an implant that I developed probably 22 years ago, and there have been some modifications since I developed it, but it's essentially the same thing, and it's just a kind of a buttress that goes in place of the radius that we're removing. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So I'm making kind of a dorsal lateral approach to the antebrachium. And I do the dorsal lateral approach for two reasons. One is that it allows me to avoid the blood supply, and two, it means that the incision is not directly overlying the plate, which means that it's a little bit less likely that you're going to have an erosion through the skin due to the presence of the implant. We're getting a little bit light.
Yeah, just reactive already.
Yeah.
I feel like it's too large to start with. So can you just add some more metal?
Yes.
0.2 millimeters.
Yes, and give him some Alfax to start with.
Yeah, he's had some alpha.
Okay.
Can I go with another 0.2?
Yes. So I'm palpating radius right here, and that's ultimately what we need to get to. And because we're doing an arthrodesis of the joint, we don't really need to worry about a lot of the muscles in the distal extremity as far as preserving function is concerned. And it's interesting that these guys now take me about an hour and a half. The first limb spear that was ever done by Rod Straw at Colorado State University took about 14 hours because they were being so careful about preserving every nerve and blood vessel. So we've just discovered that you can actually get away with removing a lot of these structures. Grab another Gelpy. And so it's important here that we stay out of the tumor capsule, otherwise you're going to get a dirty margin. I'm palpating the ulna right down here, and the ulna will stay intact. That's the collateral ligament down there. So that's radius just right here. So this is distal radius down here. Can we get ligashore, please? So that's the radiocarpal joint down there. So that's the distal ulna right there, and we're going to disarticulate the radio-ulnar articulation. And again, a lot of these tendons down here are going to be redundant because we're going to fuse the radiocarpal joint. And I'll sacrifice a lot of the flexor or the extensor tendons as well. We have our limb spare plate out already.
This one? You want it?
Yes, please. And can I get another set of number 3 Gelpies, please? So I'm just exposing the dorsal surface. Here are some of the tendons that I sacrificed proximally. So I'm down onto the ulna here. The main reason to preserve the tendons is to provide some soft tissue coverage over the plate. So the patient's going to have only chemo after the surgery. No need for radiation if we've gotten a clean margin. And that's a distinction that a lot of people don't understand, is that chemo is almost exclusively for systemic metastasis and radiation is almost exclusive for primary tumor. So I'll just flex this, and I'm just going to cut into the radiocarpal joint here. So that's joint capsule for the radiocarpal joint right there. And one thing that I'm going to do is that when I make my arthrotomy down here is check the articular surface to make sure that we don't have evidence of a articular fracture, pathological fracture from the osteosarcoma.
I'm passing the sen.
So I'm just looking at that articular surface, and that looks fine.
Thank you.
All right, now I have the radial shaft right here, and this is the radio-ulnar articulation out here. And often what we do is we'll shave a little bit of the ulna and take it out with the radius just in order to make sure we're getting a complete margin. What usually happens is these guys are basically bloodless until I get to a certain point, and then it just starts bleeding and you're getting all the interosseous vessels and stuff like that that are really hard to control. So we don't need to preserve the collateral ligament here, again, because we're doing a fusion. So I'm just trying to get a better look at the ulna here. This guy, I think. All right, so I need a saw. Do we have a saw blade already, please? Can I? Yep. Okay. Can I get a smaller saw blade, please? Next size down. the tumor is in here, yeah.
Have you got a white one up there?
Okay.
Have you got a white one, or are you good?
Yeah, a wide one. And often we'll try to maintain the attachment from the ulna to the carpus intact, because that can provide a little bit of support. All right, and so my articulation is kind of in this direction like this. Move that out of the way just a little bit. Can I please have a osteotome and mallet? Just going to say that's usually when I hit the interosseous vessel. So I'll just pack that off for a minute. Size, do we have the whole tray? That's great. Yeah, that's great that we've got the whole tray there. So we'll get a nice fat one here. So the next thing I need to do is disarticulate the radiocarpal joint. You can add a lap sponge, please. And then just pack it in here. Okay. So this is the collateral ligament for the radiocarpal joint. There's actually a little cruciate ligament in the carpus that you have to sever. Right back in here. Now what I'm going to do, let's make sure you're not in the way of the camera here. All right. Where is the limb spare implant? Okay, so what we'll do is I'm going to use this to mark where on the radius we need to cut.
Are you able to move the camera a little bit?
I can't, sorry. So where's my cautery? I'm just trying to make sure that Aaron keeps his big head out of the way. Okay, so that's where we need to make our cut. So that's the implant that's going in. And I've got a Homan somewhere here. Okay, and just get a freer elevator on the other side. Okay. On the saline, please. And I chose my implant based on knowing that by removing that amount of bone, I would feel confident that I was getting a clean margin. All right, so now grab onto the radius here, which is now loose. Speed locks are not very good. And they're not particularly grippy.
Getting a bit dull.
Maybe. Alright, so just try to rock that down like that. I'm going to try to gently grab on here. I don't want to penetrate into the bone. Can you come around and pull away on the foot? Okay. interesting, we don't have an issue with blood supply on these guys distally. Like I've never had one necrose its digits or anything. Okay, so this is our tumor bone here. Let's just pack that off, please. So that's the tumor bone that we've removed right there. And the endoprosthesis comes in two different sizes. Comes in a 122 and I think about a 98. All right, so let's just externally rotate that so I can see. And suction, please. So that's just the interosseous vessel, and that's the one, if we did an ulnar transfer, that's the vessel that we would use. So we'd keep that intact. So, a little bit of a bleeder. Often it's coming from the medullary bone, medullary canal. Alright, so let's see if our implant will fit. Now, where is the endoprosthesis? So that'll go in there, like that. Now, occasionally I have to trim away a little bit more bone. In this case, I'm just going to cut off the carpus. And we don't have to do a proper arthrodesis in that we don't have to go in and remove all the articular cartilage. When these fail, where's the other blade? When these fail, they only fail proximally, they never fail distally. Alright, so now what I'm going to do, where is that coming from?
I think it's the intra-osseous one, so that's just
So, now let's externally rotate that. And I'm just going to, just make sure we can still see, I'm just going to clean off the dorsal surface of the carpus here. I'm doing that for a couple of different reasons. One is to just get better exposure to see what I'm cutting, and two is so that the plate will fit squarely up against the bone. So let's just have one more look here. Where's our endoprosthesis? One more look to see how much I'm going to have to take out. I think it's going to be easier. I'll just cut that flat and then I'll take out a little bit more of the radius. where's my freer elevator? Alright, and we'll remeasure here to there. So let's get a Homan or something behind there. And just protect the soft tissue with the freer elevator. Interosseous ligament that's still intact there. Okay, so now for the next part, what we'll do is I'll attach the plate to the prosthesis. We'll decide exactly where we want it to go. Say probably like that or like that. Go like that. So do we have the other screws? Can you open those for me, please? Are those hex or star?
Those are hex.
Okay. So then I attach the prosthesis to the plate using these little machine screws. And I'm not going to contour this plate at all because the screws we're putting in are locking, for one thing, and for another, there's a biomechanical advantage when you leave the plate straight as opposed to putting a curve in it. Now, the other thing I need to check before we get started is that I have enough room proximally before I get to the radial head. So the radial head is right there. Yep, so that'll be fine. All right, so now I'm just going to lay this, and I usually go for kind of the third metacarpal, like this, and so now I'm going to have to take there's a bony protuberance on the fourth metacarpal there. All right, on the third, sorry. So that'll just sit just like that. I think you guys can see that, yep. And this endoprosthesis is off the shelf, meaning that it's not specific, it hasn't been custom made. When I developed these, I wanted to make it really easy for you to just be able to have one size on the shelf, and it would work with any patient. I'm extending my skin incision proximally.
So since it's fusing, we don't have to worry about protecting the radial nerve.
No, radial nerve is still important at this level because I think so.
Extensor to
Yeah.
extensors.
So where is our Gelpi retractor, smaller one? So the real challenge is actually getting enough of the proximal radius exposed that you can get the plate up there. got the pronator exposed there. And you can cut these plates shorter. Okay, so that's good there. So I'm going to leave that underneath the soft tissue. All right, now the next thing that we do is I'm going to use a freer elevator to establish the joint between the metacarpal bones, yeah. Can we open the 2.7 kit, please? Yeah, thanks.
You need a drill guide?
Yes, please. So I just need to make sure that it's lined up with the metacarpal all the way down. Go ahead and load up a 2.0 drill bit. Do we have non-locking screws in here as well?
Yes.
Regular cortical.
Yeah.
So are those the 2.7 locking?
Yeah, they're all recessed down in the thing.
They seem so small. Let me just see if that... Yep, that is correct. So I'm just going to use a cortical screw in the first one to try to pull the plate or the bone up to the plate. You might change that over to, yeah, there you go. Depth gauge. So that's measuring about 0. So I'll add 4. So that's measuring 26.
Yeah, 26.
26, 27. So I'll put in a 30. That might be a hex though. And what this screw is going to do is as you tighten it down, it's going to pull the bone up against the plate. And that's the beauty of using a cortical screw instead of a locking screw. The locking screw won't do that. Okay, and then we'll go down to this last screw down here. And I'll probably do a cortical down here as well. So go ahead and drill that one. And I always attach it to the metacarpal first because that's a lot harder to align than the radius. Your head's going to be right in the way there. Okay. And I won't add anything to the length on this one because it's already come up off the... go 18. Yep.
That's a start.
That's it. Okay, that's great. Any tighter?
I think so.
Okay. Now we'll go back to our drill. What I might do is have you come around the side here. And we'll turn that up like that. So if you align the top and the bottom, then you know that the rest of them have to be aligned. And you know that you're in the center when you get that separate clunk when you're going from one cortex to the other.
Locking or cortical?
Locking, and we'll go 16, please. Just hold that still for me. I'll go back and hand tighten them all afterward. Can you tell me the time, please?
Yeah, 5:15.
5:15?
Yeah. And a couple of
We'll go 16 again, please. Okay. Well-oiled machine, Aaron and I. Sorry, Sean and I.
Hope so.
18, please.
Would you feel all?
Yeah. This will be longer because we're getting to the top of the metacarpal. $20, please. Let's get into the carpal joint. 28, please.
juice.
You want another battery?
Might be just that the bone is so hard.
Yeah.
Yeah, that's pretty solid.
Cutting flutes on the corticals, locking is not
Yeah.
as well. A workout. Good thing you're not going fishing over the weekend. Or
Yeah.
are you?
No.
Charles getting his workout in.
Now I'll leave that one empty, and let's switch over to 3.5 cortical. So we'll use a 2.5 millimeter drill bit, and I've got 2 loaded holes here. So 2 loaded holes here and here. So that's going to allow me to compress a little bit. So I won't need that, I'll just need the 2.5 mil drill bit. And I'll load that hole. Can I get a bigger depth gauge, please? I'll take a 20, please. And then again, this is going to compress the interface between the bone and the...
Corticals, 3, 5, 20. 20.
Yeah, thank you.
Thank you. Did it always have that hollow core?
Yeah, they changed it a little bit since I first made it, but it's very, very close.
20, right?
Yeah. We hollowed it out to make it just a little lighter. It used to be just a solid core. Can you hold the legs still for me, please? Let's get a new battery if we could. Just see if that's... So as we tighten that screw, it's going to compress the interface. And I'm just making sure that I've got bone stock underneath the whole top of the plate up there, which I do. Although I could probably spin it around a little bit. Just release that, and then I'll take a bone clamp, please. What I'm going to do is grab onto the bone and the plate and slide the bone around like that. And that's just going to align everything a little bit better. Now I can tighten this again. Now I've got better coverage up here, and everything's aligned at the interface as well. Is that all right? Let's change over to the 2.8 mil drill bit. Thank you. That battery's no better.
Yeah, I think it's even worse.
Yeah.
Yeah, that's the second time there.
4. I'll take a 20, please. Locking. And is that's my 2.8. Helps if I put it in the one that I drilled.
It's self-tapping, but not self-drilling.
Yeah. The ones that we used to use for Chiari and stuff, they're actually self-tapping, self-drilling, and yeah. So you just, they're so tiny and so sharp that you don't need to pre-drill them.
That's those tiny, like 1 millimeter.
Titanium, yeah, yeah.
Sure, in between switching that stuff out.
20,
20?
yeah.
And just put that battery in the extra piece you got and see what that sounds like. Yeah, not bad.
So sad.
Okay, switch that over. I'll hand tighten this one. I'm not going to put in a screw at the osteotomy because it's too close. Okay, and I'll need a Homan up at the top eventually. And these really far proximal ones, sometimes they get into the ulna. And so you want to be careful because if you have the end of a screw that's pushing up against the ulna, it can cause pain when they're walking after surgery. It's measuring 30 and I'm not sure why.
Use the 20, the one, and a 20 mil cord.
I might have gone up against something else. It's still 30. See where's my cautery? If I expose, that is definitely not 30. So I think I probably got into the ulna a little bit. I'll take a 20, please. And I don't typically put a drain in here, even though there is dead space, because as we know, drains actually increase your risk of infection. And get rid of this guy. And then just move my Gelpy up a little bit higher. And a drill guide. $20, please. Just see how. That was a 20.
On its last legs.
Yeah. Think we'll get the last one.
Probably.
And
Extensive carpi,
radialis, yeah. And this should be our last screw.
Oh, just.
Just keep that in there.
Thank you.
22, please. Time?
It's gone 5:30.
To be in China in a half an hour. And just go back through and make sure all my other screws are tight. I may have been getting a little weak. we'll come around here and do some lavage. Take this out, make sure that you've got reasonable range of motion from the elbow, because if you lock the radius to the ulna, you can reduce range of motion because there is a little bit of translation between the two. So that feels really good. Legs on straight. So now we'll go ahead and do some lavage.
Yeah.
We get some OPDS, please.
Oh,
Just
that's
watch your
fine.
head.
Fine.
All right, so now what you're going to do, you're going to close that muscle as far down as you can, and then it's going to be pretty much just an intradermal.
We'll get some alkyne to hold the skin in place later.
Yeah, and it might be easier to get the op site off as you're doing the intradermal.
Yep.
Okay, happy with that?
Happy.
All right, so let's just show one more last look at the whole finished process.
Shiny leg. Give it a nice polish before we close.
Yeah. All right, so just muscle and then basically intradermal.
Sounds
Okay,
good.
I'll just come over and make sure I haven't missed any questions. And that's pretty much it. All right, so this is just going to be an intradermal skin closure that I'm going to leave Sean to do. And that's pretty much it. I do hope to stream some tomorrow. And I hope to see you then. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream.